Good evening, everyone. How are you all? Welcome to First Aid AMC MCQ free 2-week sessions again. So tonight is going to be a very, very important session, which is cardiology. Cardiology is one of the most important medicine topic for your exam. So we take two classes on cardio, and then after that, we will do a cardiology question solve class as well. And you just had 2 random question solve classes as well, right? So it's a good time to do some theory now that you are well oriented with how the questions can come in exam. You can also find out that how much deficit you might have to prepare for this exam. Because many things that, well, it's an easy exam and I've been practicing forever, so I know everything. But when you actually start doing the questions, then you know that where is the weakness. You know that, well, I need to learn. I need to gather a lot of knowledge, because even though I feel that I know a lot of things, but I'm still struggling to solve questions. So I'm sure that many of you are feeling this way after having those random question solve classes, right? So the idea of random question solve class is to give you an idea that how the how the exam questions can happen, because those are simulated questions. Those questions follow all the rules of exam. So you'll understand from those questions that it is not super easy. Even though you know about a particular topic, the questions can be quite tricky. The options sometimes can be like 2 or 3 options might be right, and you need to choose the best option out of them. So if you don't have a good knowledge on the theory, it can become very hard. Okay? So let's move on. So we are going to start with cardio. So every day I get few of you who has difficulty to hear. So let me just write in here. So for Zoom, you need to join with computer audio. Okay, moving on to cardiac theory. So cardiology has a lots of pathophysiology to understand. If you have a good knowledge, if you have a good basic on it, it's not very difficult, right? So let's have a look at how a heart pumping action usually occurs, and then we will start the class.
The normal heart has two sides, a right side and a left side, and four chambers, the top receiving chambers, or atrium, and the lower chambers, which are thick-walled pumping chambers, called ventricles. Red blood cell will come from either the superior vena cava or the inferior vena cava and enter into the right atrium. The blood then flows across the tricuspid valve to the right ventricle. The right ventricle then squeezes and ejects that blood cell into a vessel called the pulmonary artery. Pulmonary artery splits into two vessels, each going to the lungs. As that red blood cell makes its way through the lung, it returns through the pulmonary veins to the left atrium. That blood is now oxygenated. It's picked up oxygen, then goes across the mitral valve into the left ventricle, which does most of the work in terms of delivery of blood flow to the body. That blood cell is now ejected into the aorta to some organ or muscle or skin in the human body.
So that's a very good video, and it's a short video of how heart works, but still there's a lot to learn. So we will go with a bit of discussion about cardiac pathophysiology, or let's say just a physiology of cardiology, that how cardiac system works, and then we will go ahead with our class. So the research that you need to follow for cardiac preparation is this. So for any theory session, we always advise that what are the main important research that you need to follow? What are the books or topics you need to go through? So just like cardiology, so you can see that John Murtagh 8th edition has got most of the important topics related to cardiac. So chapter 30, 59, 75, all of these are cardiac chapters. And these are very important, and we will cover these chapters in our class. Sometimes Kaplan Estate to CK, which is the USMLE Estate to CK, it's our additional books. So many times we like to go through Kaplan Estate to CK for theory because John Murtagh has a lot of things, but sometimes it's not good enough. So some of the topics we like to go through Kaplan. For any medicine topic that we discuss, RACGP is the Australian guideline that you are supposed to follow. So if you want to know a little bit more about myocardial infarction or angina, then just write angina RACGP or myocardial infarction RACGP in the Google, and those guidelines are very important to follow. Our lecture note will have all the things included. So a few things we might discuss from John Murtagh, but most of the things will be included in the lecture note. And then you get a Q bank and solve some Q bank questions, and that will give you the extensive knowledge about a topic. So our advice is that when we do a topic, you are supposed to go through our lecture note. And if you miss the live session, then at least do the recorded session. Once you finish our lecture, then you start, if you want to, then you can read John Murtagh chapters. You really don't need to because we cover everything. If something you need to do from John Murtagh, we ask you to do it. Otherwise, lecture note will be enough for important topics like cardiology. Kaplan Estate to CK, you don't need to read it by yourself. We will include that in the class. But any of you who wants to improve your basic or theory, even after the class, then you can definitely take these two books for your guideline. RSCGP guideline, if something is important from RSCGP, we will show you. And once you get an idea about the theory from this, then go and solve some questions. So there are lots of QBank available. Any of the QBank will do. So after doing, let's say 20, 30 questions, you will get an idea that how you're doing with those. And if you're doing good, if you can come to a right answer from those QBank, it means you are ready to finish this topic. Then we want you to go into our portal. And in the portal, you'll see that there is a cardiology mock test. So then you go for the cardiology mock test and see how much mark you have got. So that's the way of preparation for each topic that we discuss in the course. Okay. So the first topic for tonight is chest pain. And the chest pain, there is a chapter in John Murtagh as well. So chapter 30 is the John Murtagh chapter, which is the chest pain. And that's what we are discussing now. We will go into this chapter later on at the end of the class, just to show you that what are the important things that you can go through from here. But first, we are going to give you a basic idea about this. So chest pain is a very important topic. Our tonight's session is solely based on chest pain because there is a lot to cover. Able to hear me fine, or what's really happening? Okay, let me check. Is it okay now? Yep, better. Okay. Just go through now. So the volume should be fine. So I think it should be okay now. Okay. So we were discussing about what are the research that you need to follow. So ideally, you need to make sure that you go through these topics. So normally you are supposed to finish John Murtagh. These topics will be discussed in the course. Kaplan step to second, we will discuss the important topics. So you don't need to go through alone. RSCGP guideline is really important for any medicine topic. So if you have some time, go and have a look in the Google. The lecture note is the most important part of your preparation because it usually have most of the important topics. Sometimes we might ask you to go and do some reading from John Murtagh, some specific topic, then you will do it. And once you have a good preparation from a theory, we want you to go to a QBank and just make sure to solve at least 20, 30 questions. And after that, you can go into our cardiology mock test. And in the cardiology mock test, if you get really good mark, like at least more than 50%, then it means that you are good. That means you have done this theory really well. Yeah, so all the copy of any of the books that we're talking about will be provided in the course. So is the sound is still a problem? Because my volume is fine. So you should also try in your end that if your volume is low, because my end, the volume is completely fine. And I'm really talking loudly. Should not be muffled. Very unlikely that it is muffled. Is it for everyone that the audio is muffled? Is it different from the other two classes that we have taken? Okay, let's check now again. Should not be muffled because you guys really need to hear well to grab this class. And I would hate that if the audio is not working. Is it working now? Okay, great. Okay, so don't know what happened, but let's proceed. Okay, it might be my ear plug. Okay. All right. So we're moving on to chest pain. So I've shown you that there is a chapter 30 in John Mutag 8th edition, which is the chest pain chapter. So we will mainly take help from John Mutag as well as we'll also cover a few things from Kaplan Estate to CK. So I want you to follow the lecture now, and then we will go into the John Mutag. Again, it's muffled. Okay, let me just restart the class. Okay. Okay, how is it now? Okay, if it gets muffled again, just let me know, okay? All right, so moving on to chest pain. In the chest pain, what we normally would like you to know is it's not only the cardiac causes that usually brings a patient with chest pain, but patient with lots of other organic problem like vascular problem, respiratory problem, GIT problem, any of those can also present with a chest pain, right? So what are the differential diagnoses for a patient who comes to us with a chest pain? So cardiac is the most important cause. So we want to rule out myocardial infarction, angina, pericarditis, mitral valve prolapse. That's also important to rule out. Then we have got vascular causes. So aortic dissection is a very important cause of a chest pain. Then respiratory system. So respiratory system will include pulmonary embolism, pneumonia, pneumothorax. Pulmonary neoplasm, very unlikely that it will come with chest pain, but these are the main three causes. There are GIT causes, which is esophagitis. We have peptic ulcer disease, esophageal tear. Any of these can also come with chest pain. Musculoskeletal causes are there. So could be a costochondritis known as TG syndrome. Fractured rib can come with a severe chest pain. Sometimes even a herpes zoster can come as a chest pain. So you can understand from this that there are lots of causes of chest pain, right? So, but which one is the most important thing that we want to rule out? The most important cause of chest pain is myocardial infarction. And that is the first thing we would like to rule out in a patient, especially if it is a middle-aged or elderly patient, right? So it's a good idea to have some idea, like it's a good idea to have some knowledge about these causes, because sometimes all we think when a patient comes to us with a chest pain is that, well, this is a MI patient. Not all chest pain is a MI pain. That's also important to remember. So we are going to discuss a little bit about the characteristic of the pain. Sometimes the type of the pain, radiation of the pain, the characteristic of the pain can help us to come to a right diagnosis. Like if it is a case of coronary syndrome, such as it could be ischemic heart disease, could be myocardial infarction, the type of the chest pain described by a patient is kind of a tight feeling. So I'm feeling very tight in my chest. I'm feeling very heavy or pressure. So heaviness, tightness, pressure feeling, usually on the left side of the chest, that's the time we would think of acute coronary syndrome. Sometimes patients with acute MI can even present with a epigastric pain. So if it is a middle-aged or elderly patient, presents with a sudden onset epigastric pain, you should also try to rule out myocardial infarction because that can be a presentation. Nausea, vomiting sometimes can be an associated symptom in acute coronary syndrome. Some patient can even have dizziness or fainting. So these are usually the symptoms of acute coronary syndrome. So sudden onset of left-sided chest pain. Pain will radiate to the neck, jaw, or left arm. Associated with nausea, vomiting, sometimes dizziness, shortness of breath, excessive sweating. All of this can be found in an acute coronary syndrome patient, such as myocardial infarction. And the patient will complain that the pain will be 9 by 10, 10 by 10, so severe pain. And patient complain that it feels like someone is sitting on the top of my chest, like pressured or heavy feeling. So characteristic of the pain is really important to come to a diagnosis, okay? Whereas if a patient complain, no, it's not like a heavy feeling, rather it is a sharp knife-like chest pain, and patient can pinpoint that, yes, this is exactly where the pain is. It is unlikely that it is ischemic pain. Likely chance that sharp stabbing knife-like pain sometimes presents in acute pericarditis. And those times, patient will say that whenever they lean forward, the pain gets better. Whenever they lie down, the pain gets worse. So pericarditis pain is like this: sharp, knife-like stabbing pain, can be left-sided, can be retroesternal. Pain does not radiate to the jaw, neck, or left arm like MI, but it has some association with posture. Like they will say that whenever I lie down, the pain gets worse, but whenever I lean forward, pain is fine. Myocardial infarction usually associated with a chest pain that lasts more than 20 minutes. So we say that stable angina, the pain duration is less than 5 minutes. Any pain which is more than 5 minutes, it's not a stable angina anymore. Could be unstable angina, could be acute myocardial infarction. We'll talk about all of this angina MI in detail today, so don't worry. Response of a chest pain to nitroglycerin. Sometimes question will give you the clue in exam that patient has got a chest pain and the chest pain is getting better with nitroglycerin. If a chest pain responds well to nitroglycerin, it goes with ischemic heart disease. One other chest pain which also gets better with nitroglycerin is esophageal spasm. So either it is ischemia or a spasm if nitroglycerin makes it better. How about the chest pain that gets worse with nitroglycerin? So it can be a very important clue. So if it gets worse with nitroglycerin, it is likely to be gastroesophageal reflux disease. Okay, so these are important things that can give us some information in the exam that whether it is acute MI, whether it is just a esophageal spasm, whether it is a pericarditis. Now, there are some physical examination findings that can also help us to come to a diagnosis in the exam. Like if we have got a patient who has pulmonary embolism, which is like a clot in the pulmonary artery, that patient physical examination finding usually will be tachycardia and tachypnea. So high pulse rate, high respiratory rate. So these are not like super important, but this gives us a lot of information in the exam. This helped us to come to the right diagnosis in exam. Sometimes, if there is a fever with a chest pain, you would think of an infective cause, such as pneumonia or mediastinitis, because none of the other causes of chest pain usually have fever except pneumonia or mediastinitis. If there is a huge difference of blood pressure in both arms and patient has a severe retroesternal chest pain, it can indicate possibility of a aortic dissection. So let's say that right arm systolic blood pressure is 140, whereas left arm systolic blood pressure, let's say 160 or 170. So when there is more than 20 millimeter difference of systolic blood pressure in both arms, and patient has other features of aortic dissection, this can be a very important clue to your diagnosis. So this science helps us to come to the right diagnosis in exam. Okay. So these screenshots are from Kaplan step 2. So we will go into John Murtagh later on. There are sometimes in exam questions, they will give you abnormal heart sound and murmurs. You need to remember that everyone, like a normal person, will have a S1 and S2, so first and second heart sound. That is normal. Without first and second heart sound, you are a dead person, right? So, but there are two other abnormal heart sound. So that's third heart sound and a fourth heart sound. A new fourth heart sound can be found in a MI patient. Whereas if it is a S3 gallop rhythm, that can be a finding of CCF or heart failure. So why we are showing this to you is that sometimes the questions will be very tiny. They will not give you lots of information, maybe one or two. They can say that, yes, there is a new fourth heart sound. And if you know that a new fourth heart sound can indicate angina or infarction, that will really help. In the same way, a new S3 gallop rhythm can be found in an underlying heart failure patient. Okay? Blood pressure difference in aortic dissection. Now that you know that what are the signs and symptoms of different chest pain, let me discuss a very important physiology of cardiac system. So I'll just open my whiteboard. It's basically a blue board anyway. So first, let's have a look that what's the physiology of cardiac system, because sign and symptom, you don't even need to know the physiology, but when you actually want to diagnose a patient by test, by other examinations, you need to have a good idea that how heart works. So let's see. So this is your heart, let's say, and we have got 4 heart chambers. So we have got atrium and the ventricles. And then each of these chamber is divided by some door-like structure, which is the valve. So we have got valve here, we have got valve here, and there are 2 other valve as well. So this is right atrium, that's left atrium, left ventricle, right ventricle. Now let's have a look about some of the other things. So we have got superior vena cava, we have got inferior vena cava. So SVC and IVC, blood from upper extremity will come into the right atrium through this superior vena cava. Blood from lower extremity will come to the right atrium through inferior vena cava. Okay, so all the bloods, that means the carbon dioxide blood or deoxygenated blood. So these bloods are carbon dioxide, not oxygenated. So this deoxygenated blood will come from all extremities into the right heart, into the right atrium. And from right atrium, through the tricuspid valve, it will go into the right ventricle. Now in here, we have got a pulmonary artery. And in here, we have got the pulmonary valve. So from right ventricle, the deoxygenated blood will flow into the pulmonary artery. And the valve that will regulate that is the pulmonary valve, right? So what pulmonary artery will do? Pulmonary artery will take all the bloods into the lung. And in the lung, we have got the alveolar capillary system. So what happens in here that so in the lung, the carbon dioxide blood or carbon dioxide will come into the alveolar area. And in here, we have got the capillaries, right? So what will happen is that in here, there will be gas exchange. So the oxygen, or you can say that when you are, sorry, so this pulmonary artery becomes capillaries, like a small blood vessels, and it has the carbon dioxide blood, right? So this carbon dioxide blood And so when you inhale from the airway, the oxygen comes into the alveoli. So in here, the oxygen will come into the lungs and the carbon dioxide will be exhaled. Does it make sense? So this is the alveoli and this is the lung capillaries. So in here, the gaseous exchange will happen. So when you inhale, you are actually taking the oxygen in. So this oxygen, through the alveolar capillary membrane over there, it will be diffused into the capillary. So oxygen will go into the capillaries and carbon dioxide. So this carbon dioxide blood will go into the alveoli and it will come out. So that's what happens. Like we take oxygen in and we exhale carbon dioxide out. Now this blood is oxygenated blood. So oxygenated blood will be carried by the pulmonary vein. So from here, so let's say the pulmonary vein will carry the oxygenated blood and it will bring the oxygenated blood into the left atrium. Then through the mitral valve, the blood will go into the left ventricle. So oxygenated blood will be carried by pulmonary vein, comes into the left atrium, through the mitral valve, it will go to the left ventricle. Now from the left ventricle, we have got the biggest blood vessels, which is the aorta. And in here we have got the aortic valve. So from left ventricle, blood will go into the aorta. Excuse me. So through the left ventricle, blood will go into the aorta and then through the aorta, it will reach to all organs of the body. So that's how the deoxygenated blood will be oxygenated in the lungs and then it will be carried back to the heart and then heart will pump all the oxygenated blood into the system. That's how human being lives. If this process is not there, we are dead, right? Did it make sense, guys? Any questions with the physiology of cardiac system? Brilliant. So if you understand this, it becomes very easy in the exam to even come to a good diagnosis or the right diagnosis, because this helps a lot. If you don't, if you close your eyes and you don't know how the heart works, you can't get these questions right. Because now that you know, if you close your eyes, you know that how this is working. And that's really important before you can even learn something. So physiology is the vital, it is the basic, and the based on that you can actually pass any exam in your life. Okay. All right. So we were talking about chest pain. And the reason why we have shown this to you, you will understand later on that what is the main reason and why it is important to know. Because we need to know about heart failure. We need to know about cardiac output. So all of this will come into play when we discuss those things. Now, let's say we have got a patient with chest pain, 50-year-old coming to us with a 2 hours of left-sided chest pain. What is the first test that you would do in that patient? Yes, everyone is right. So we will definitely do a ECG. So nothing will come before that. Let's say we have done the ECG. What is the next step? The next step is the cardiac enzymes. If you have got a ST elevated MI, then we don't need to even wait for the cardiac enzymes. But if there is no ST elevation, then yes, cardiac markers will be important. So what is the main cardiac marker? So cardiac troponin is the main cardiac marker. There are lots of others, like we have CKMB, we have myoglobin. So any of these can be done, but nowadays all we do is troponin, nothing else. We don't need to even do the CKMB or myoglobin, but we need to know. So CKMB is typically detected in the blood 4 to 6 hours after onset of the chest pain. And it can get better within 2 to 3 days. So that's usually very good, well written in here. So CKMB, it will get abnormal 4 to 6 hours after the chest pain, and it will come back to normal. Sometimes they say 1 to 2 days, but max 3 days. So within 3 days, it will come back to normal. Whereas troponin also takes 4 to 6 hours to get raised, but it will stay in the blood for 2 weeks. Myoglobin, very short life, so 1 to 4 hours, and usually it will just be normal within 1 to 2 days. Very rarely we would ever do myoglobin in these patients. It's just not done at all. But CKMB has some kind of help, especially in reinfarction. Because let's say you have treated a patient who is currently having a high troponin, and you think that patient has got a acute coronary syndrome, either a ST elevated MI or non-ST elevated MI. And this chest pain started, let's say, 4 days ago. You have treated the patient, so you have treated with, maybe you have even put a stent in that patient. But after 5 days, patient is complaining chest pain again. Now you think that this patient might have a reinfarction. For a patient who you think can have a reinfarction, troponin is not the best, because even if you treat, troponin can stay elevated for 2 weeks. So it will not give you any idea that you really need to know. So the only time nowadays we would do the CKMB is when we think that there is a possibility of a reinfarction. Okay? So we have got an idea about the CKMB. We know about cardiac troponin. So moving on. Sometimes chest X-ray can be done if you want to rule out some other causes of chest pain, like pneumothorax, pneumonia, pleural effusion, those cases, so respiratory causes, then we can do a chest X-ray. So we discussed a little bit about the causes of chest pain, so aortic dissection, pulmonary embolism, pericarditis, and also several others. Now, we will discuss each and every one of them in detail. But let's have a look at how we can differentiate a acute myocardial infarction pain from aortic dissection pain, because both of them will come to us with a very sudden, severe chest pain. So we know about acute MI, how the pain presents. It will be acute onset, left-sided chest pain, radiating to the left arm, neck, or jaw. And it feels like a tightness, heaviness. Whereas if it is an aortic dissection, the pain is usually retroesternal, so central chest pain, and pain will be much more severe than even MI patient. The pain is sharp, excruciating, tearing sensation, and it is extremely severe. And very important clue is that chest pain, which is retroesternal, radiating to the back. Okay? So that's how we differentiate between these two. Sometimes, as I said, that you can get some difference of systolic blood pressure if you do it on the both arms. That can be found in dissection patient. If you do a chest X-ray, you can get widening of the mediastinum. But the confirmatory investigation for aortic dissection is TOE, which is transesophageal echocardiogram. Sometimes if toe is not in the option, we can do a CT angiogram as well. So both of these are correct, but most specific to diagnose aortic dissection is transesophageal echocardiogram. Clear? We will not discuss about pulmonary embolism because it will be discussed in respiratory system in detail. Pretty important topic. We know about pericarditis. Pericarditis pain is not as severe as MI or dissection. It has a classic pattern. So a patient comes to us with a sharp pain, stabbing pain, but it has this kind of positional change. So whenever they lean forward, pain is better. Whenever they lie down, pain is worse. They also say when they take a deep breath or they cough, the pain can get worse. So that's called pleuritic chest pain, which gets worse with inspiration. Many times, pericarditis pain can happen with a like a 1 week history of upper respiratory tract infection. That is the most common cause. So they get a viral infection, maybe just a flu, and after that, they get this kind of sharp stabbing chest pain. There might be a pericardial rub present sometimes on auscultation, not always. And when you do a ECG on this patient, you will get a global ST elevation. We will show you how this ECG looks like in our ECG class in the course. Okay, but definitely there is a ST elevation throughout the whole leads and all the cardiac enzymes will be normal. And then you can confirm that it is pericarditis. Now, if we look over here, this is kind of a good discussion about various chest pain. So we know about MI, we know about pericarditis, we know about dissection. Few things like costochondritis. So costochondritis can be a cause of chest pain. Sometimes can be very tricky as well. So if a patient say that whenever they press the chest, it is tender to touch. So costochondritis is nothing but the inflammation of the costochondral junction. So it is just proximal to the sternum. So if they complain pain over there, and when you actually press the costochondral junction, it is quite tender. Even sometimes you can feel a swelling. Then it is called costochondritis. And it's a inflammation, so anti-inflammatory will work really good for this patient. Okay, so this is mostly about all the causes of chest pain. Now we are moving more towards the acute coronary syndrome or ischemic heart disease. So far, everyone is clear? Brilliant. First of all, what are the risk factors of ischemic heart disease? So one of the most important risk factor is elevated cholesterol level. So if they ask you that what is the single most important cause of heart attack or ischemic heart disease, so single most important is high LDL cholesterol. Do you know what is the ideal LDL cholesterol for patients who we suspect high risk for myocardial infarction? What should be the ideal value? So the ideal value is less than 1.8. Okay, so 70 is that I think milligram per DL. So that's the 70 we're talking about. But in Australia, we don't use the milligram per DL. Okay, so it is in here. I think it's what we use is micromole or millimole per liter. So it is the less than 1.8 is the appropriate value for LDL cholesterol. And if we like to keep it below 1.8 to reduce any risk. Now, how the question will come in exam, that will determine your answer. So if the question say, what is the single most important risk factor for ischemic heart disease? That is cholesterol, or more importantly, LDL cholesterol. If the question asks, what is the worst risk factor? That is diabetes, because if a patient has coronary artery disease and they have diabetes, it just gets very complicated. What is the most common risk factor? That is hypertension. So try to remember these three questions. One, single most important risk factor, worst risk factor, and most common risk factor. Like the question asked here, which of the following is the most dangerous to a patient in terms of risk of coronary artery disease? So we know about this. So elevated triglyceride, elevated total cholesterol, decreased HDL, elevated LDL, and obesity. So we know that elevated LDL is the most dangerous according to this option. Okay. So if diabetes was in the option, then that would be the answer, because diabetes is the worst or most dangerous one. There is another question, correcting which of the following risk factor will result in most immediate benefit for the patient? Now, there is a different question. The most immediate benefit can be found if you can actually advise the patient to stop smoking. So within a year after stopping smoking, the risk of coronary artery disease reduced by 50%. Within 2 years of stopping smoking, the risk reduced by 90%, which is significant. So that's why we say that this is the most immediate benefit. So if a patient can stop smoking, the benefit of reducing their risk is significantly high. Moving on to ischemic heart disease. We are talking about ischemic heart disease a lot, right? So what is that? So as you can see that a normal coronary artery, the lumen of the coronary artery should be clean. So the blood should flow without any problem. There should not be any obstruction. Ischemic heart disease is a condition where the coronary artery, the lumen of the coronary artery, starts to get atherosclerosis or fatty deposition. If you see here, this is the lumen, right? And you can see that there is a bit of atherosclerotic plaque happening there. This patient might not have any symptoms because the lumen is significantly open, right? Maybe just 30% blocked. So that's not going to give any symptoms to the patient. So this patient will be asymptomatic. And that can be a lot of patients who are completely asymptomatic, but they have a bit of atherosclerosis anyway. So prevention will come into play in this group of patients. There will be symptomatic patient. So we have got stable angina, and we have got acute coronary syndrome. And under the acute coronary syndrome, we have unstable angina, non-ST elevated MI, ST elevated MI. So the difference between a stable angina and coronary syndrome is that stable angina patient will still have some lumen left. So you can see still the lumen is not fully blocked. So that's the patient who will have symptoms only related to something exertional. So patient with stable angina, they will come to you with a left-sided chest pain. The pain usually get worse with walking, running, or any kind of exertion. And whenever they take rest, the pain will get better. This kind of patient also say that if they take nitroglycerin, the pain goes away. And this pain will not last more than 5 minutes. Okay? So pain which comes with exertion gets better with rest, lasting less than 5 minutes. That's a stable angina. Now we have got acute coronary syndrome, and that has unstable angina, and we have got myocardial infarction. So if you look over this picture, this is a patient who has myocardial infarction. So you can see that there might be a bit of rupture of the plaque over there, and then it has completely occluded the lumen. When there is a complete occlusion, then we can say that it is a myocardial infarction. Okay, so now it's very difficult sometimes to know who is having unstable angina, who is having myocardial infarction just by the symptom, because symptoms can be pretty much same in this patient. So that's the time investigation sometimes will help us. So let's have a look. This is from John Murtagh. So we have got stable angina. So we talked about it. What about unstable angina? It has other name like crescendo angina, pre-infarct angina, all of this. So it is increasing angina over a short period of time, precipitated even by some less exertion, and even can come on at rest, especially at night. So this is like pre-infarction. So left untreated within weeks or days, this patient will end up having a full-blown myocardial infarction because there is an unstable plaque. So that can cause complete blockage at any time. So unstable angina means that it is the same chest pain, but the pain will last maybe 15-20 minutes or even more. Pain will come even with slightest exertion and even sometimes at rest, like patient lying down, still patient getting the chest pain. The pain will not go away with rest. Pain might not get better with nitroglycerin. That is unstable angina. So we can see that sometimes unstable angina can present as pain during the night. It could be decupitous angina, so pain that occurs when lying flat. Then we have got a variant angina or Pringe-Metal angina. Now, this is a different kind of angina, has nothing to do with block. So this patient doesn't have any coronary artery blockage. All they have is a spasm of the coronary artery. So what happens is that in response to something, sometimes even without any particular cause, their coronary artery goes into spasm. And even though there is no blockage, because it goes into spasm, patient gets the pain during that time. And pain can even happen at rest, and mostly at rest. The problem with this is that it can have this typical ST elevation. Okay, now we can only come to the diagnosis of Pringe-Metal or variant angina only after doing all the investigations, because it will look like a ST elevated AMI. But when you do the full investigation, like an angiogram, you will see that there is no blockage. That's the time it will click in your mind that, well, there is no blockage. How come this patient having a ST elevation in the ECG? So that's how, because this is how it can present sometimes. Okay, so that's called Prince-Metal or variant angina. We'll discuss about this at the end a little bit more. So why pain occurs in Pringe-Metal? Because coronary, so if this is coronary artery, that's the intact lumen. But when it goes into spasm, it becomes like this. So there will be lack of blood supply that will give the chest pain. Now, ECG is totally different from our discussion today. We will not go into ECG, ST elevation, or ST depression a lot because that's part of our ECG class. Why it occurs at night? Because now this is kind of a thing like which is getting almost completely blocked. So even when patient at rest, they are getting still a little bit of effect because it doesn't matter if patient do any work or not. The artery is getting almost blocked. So it can give pain anytime. Okay. So this is your stable and unstable angina patient. Now, we would like to discuss a little bit about the management of a stable angina. So, stable angina, because there is not much of a huge blockage, the treatment for stable angina is preventative treatment. So, preventative treatment will include healthy lifestyle. So, lose some body weight and make sure there is a good exercise pattern, eat healthy, balanced diet. So all those things, avoid smoking, reduce drinking. So all the preventative treatment will be the first line treatment. If there is any other risk factor, like patient has high cholesterol, we will treat that. If patient has hypertension, we will treat that. If patient has like problem with obesity or gaining a lot of weight, we can give weight loss treatment. So it's mainly treating the secondary risk factor is also very important in this stable angina patient. And that will just help this patient not to progress into unstable angina or eventually a MI. So what are the treatment? So if we want to treat this patient, or patient who has angina, the treatment of choice is nitrate. Nitrate can dilate the coronary artery. So whenever their artery gets a bit spasm or blocked, especially when they do any exercise, this nitrate can open up the coronary artery. So any nitrate, so glycerol, trinitrate, tablet, spray, any of the nitrate will be the first line treatment. Along with that, we can always give some aspirin just to prevent any clot formation. If patient is intolerant of nitrate, because nitrate sometimes can give a very bad headache, so we can also try nifedipine in that patient. Okay, so the treatment for episodic angina or acute attack when patient has the pain is nitrate. If nitrate is not tolerable, then nifedipine. And sometimes along with the nitrate, especially as part of like secondary treatment, as we say that if patient is having hypertension, you will start the patient with antihypertensive. We also sometimes give some beta blocker to reduce any cardiac remodeling. So aspirin, antihypertensive, beta blocker, nitrate, these are the treatment of choice for a stable angina patient. Okay, so let's just recapitulate what we have learned for stable angina. We haven't come into unstable angina yet, right? So we'll go into that. But the main difference between a stable and unstable is the time difference, the severity of the presentation. Stable angina, patient will come to us with chest pain, which gets better within 5 to 10 minutes. And it will be well responded to rest and nitrate. And it's not severe. Whereas if it is an unstable angina, the unstable angina is much more severe. Even with a small amount of exercise, the pain will come back and it can last for 15-20 minutes, even more than that. Okay, so that's how we can easily come to the diagnosis that whether it is a stable or unstable angina. So if pain persists more than 5 minutes and it's not responding to rest or nitroglycerin, we will be concerned. We will be concerned that, well, can it be a unstable angina or acute coronary syndrome? Let's have a look at this question. A 48-year-old woman comes to the office with chest pain that has been occurring over the last 2 weeks. The pain is not related to exertion. She's comfortable, retrosternal pain. Pain sometimes comes with nausea, no shortness of breath, and it does not radiate. No other history. What is the most likely diagnosis? So these kind of questions can come in the exam. So a 48-year-old woman, always remember, a menstruating women almost never have a heart attack. So that's a tip. Menstruating women virtually never have myocardial infarction because the estrogen usually helps to prevent these kind of things. So what will be your most likely diagnosis for this patient? So the pain which does not have anything to do with exertion, she's comfortable, it is retrosternal, no shortness of breath, nothing, and no other risk factor. So the diagnosis for this case is gastroesophageal reflux disease. So many times gastroesophageal reflux disease, the pain will be retrosternal because sometimes acid comes from their stomach into the, sometimes even into the throat. So they get this burning chest pain. And they can also come to us with nausea feelings because it feels like everything is coming up, right? So that's reflux. Okay. All right, guys. I think we are going into that good direction. You are catching up. So we'll take a 5-minute break. And after the break, we will go into a little bit more complicated topic, which is the acute coronary syndrome, and a little bit more about some of the investigations that we do in stable angina patient. Okay, so let's take a 5-minute break and then we come back. All right, everyone, let's continue. So, you're ready for more complicated discussion? So, when we discussed about acute coronary syndrome, it's mainly first we know about the symptoms of a patient, then we do physical examination, and then we do some investigation. So the investigation starts with an ECG, as we know. In the ECG, we will get an idea that either it is a ST elevation or it's a non-ST elevation. So two things can be there. So one, it is a ST elevation. So if it is a ST elevation MI, then we don't need to wait for the cardiac marker to treat the patient, because sometimes cardiac marker like even troponin can take 4 to 6 hours to start increasing. We can't wait for that. So if you get a ST elevation MI, the patient will be treated as a ST elevated MI straight away. No need of waiting for troponin. How about patient has like all the chest pain? We think that it is a case of myocardial infarction, but in the ECG, it doesn't look like a ST elevation. Can we just rule out MI immediately? No. Not all MI will have ST elevation. There are non-ST elevated MI as well. So when we have got no ST elevation on the ECG, we have two likely possible diagnoses of that chest pain. Could be an unstable angina, could be a non-ST elevated MI. With the symptoms, it is very difficult to differentiate between these two. So that's the time we need to do the cardiac marker. If troponin comes negative, it is unstable angina. If troponin is positive, then it is a non-ST elevated myocardial infarction. So it is that non-ST elevation chest pain where the cardiac troponin comes into a real help. Okay, so is it understandable for everyone that how to come to the diagnosis, whether it is a non-ST elevated MI, is it a ST elevated MI, or is it an unstable angina? It is not necessary to have a ST depression in unstable angina. ECG in an unstable angina can be totally normal. Now, remember one thing, that it is the ST elevated MI which is the only patient who will get benefit from a thrombolytic therapy. So this is where a lot of candidates get it wrong in the exam. So the only patient who can get benefit from a percutaneous coronary intervention, which is the PCI, which is the main treatment of ST elevated MI, or if PCI is not available, like it's a rural setting, then we have got like antifibrinolytic or like a fibrinolytic, which is like we have got streptosil, alteplase, retiplase, so any of those thrombolytics ones. So this two option is only for ST elevated MI patient. It is not effective for unstable angina or a non-ST elevated patient. Okay, so always remember, if it is a ST elevated MI, we need to, if the time permits, then the best management for that patient is percutaneous coronary intervention or thrombolytic therapy. Okay. So there is a lot of things to know about the management of this. So we'll go ahead. So we know about how a acute coronary syndrome pain looks like. So we don't need to go into that. So these are some of the charts from Kaplan Streptosike. You can give it a read in your own time, but we are moving on to some more specific management or investigation, right? So we know about like when to call it is ST elevated, non-ST elevated, or just an unstable angina. Once we make that diagnosis, what will be the treatment? Which troponin is preferred? Troponin I, more specific. Yeah. Doesn't really matter. So people do a lot of troponin T, CI. It's just not, it's not really needed to know. Now, we will come back to this stress test and everything later on, because this usually we do in a stable angina patient. Okay, let's say this is where we would like you to go ahead, and we will come back to the rest of it later on. We have got a 70-year-old woman comes to the emergency department with a crushing substernal chest pain for the last 1 hour. And ECG shows ST segment elevation in V2 to V4. So what we have got ST elevated MI, right? So 70-year-old crushing chest pain, ST elevation in lead V2 to V4. That's more than enough to say that this patient has got a ST elevated MI. Although in exam you don't get that much option, you always get 5 options. What do you think for this patient will be your most appropriate next step? So I hope you remember from our few question solve classes that most appropriate next means what is the initial or what will be your next management in such a patient. When we get a patient with myocardial infarction, the initial treatment starts with monotherapy. And mono includes morphine for the pain, oxygen if the saturation less than 95, nitroglycerin. If morphine is not helping with the pain, then we add a nitroglycerin, and A for aspirin. Now, among all this morphine, oxygen, nitroglycerin, aspirin is the most important thing to do, because this is the one which can save a patient's life. Okay, so that anytime if you have got a patient with MI, aspirin will be your initial management almost ever. So here's morphine is an option to choose. It is a right option. Oxygen can be given, nitroglycerin can be given. Any of these options are right, but you can only choose one. What will you choose? That is where exam becomes tricky always. They give you options which are all of them are right, but you need to know which one is the best option. So aspirin lowers mortality in acute coronary syndrome, and it is critical to administer that as rapidly as possible. Okay, so morphine, oxygen, nitroglycerin should all be administered, but they do not lower mortality, and therefore it is not as important as aspirin. What is the treatment for ST elevated MI is you give aspirin and you take the patient to the catheter lab for a possible percutaneous coronary intervention. Okay, so in exam, sometimes this becomes a little bit tricky, that we know that morphine, oxygen, everything can be given, but we don't choose that in the option. Because if the same question, they say that, let's say these questions, same patient, 70-year-old, ST elevation, crushing chest pain, they just added another sentence and saying you have given aspirin. What will be the next step in the management of this patient? What do you think? Okay, so most of you are right. So as you can see that even though, yes, oxygen, nitroglycerin, morphine, all of these are correct option, but in exam, angioplasty or percutaneous coronary intervention will be your option to choose, because this is the only two things which can save the life of the patient. And we don't have any time to even think of doing anything else. Now, I know that you can say that this patient has pain. Yes, morphine should be given. Yes, that is right. But the question is, like, you have given aspirin. What is the most appropriate next step? The most appropriate next step is to take this patient to the cath lab and to get the angioplasty as soon as possible. Okay, so they are asking the most appropriate next step. Now, this is where it becomes confusing. There are several management, especially something which is life-threatening. MI, especially ST-elevated MI, is a life-threatening condition. In life-threatening condition questions, we choose the most appropriate options. So the options which will save the patient's life will come over to any other kind of options. Okay, so you can see why we have chosen the angioplasty in this patient. It is associated with the greatest mortality benefit of all the steps listed in the question. All of the answers are partially correct. Yes, we do many of these for this patient, but they do not clearly lower the mortality. So morphine, oxygen, nitrate, they don't reduce the mortality in a patient who has a ST-elevated MI. So it is the thing, yes, that is right. So it is door to balloon or door to needle time. That's what we say, right? So when a patient goes into your door, you know it is a ST-elevated MI. You don't waste any time. You do the needful and you take the patient to the catheter lab. Okay, so if you can within minutes, that's the ideal. So in these kind of questions where there is a life-threatening options like myocardial infarction, pulmonary embolism, so which is like a life-threatening, the options that we are going to choose is the one that's going to save the patient's life, not something which is adjunctive. Morphine is adjunctive in here. The nitrate is also adjunctive. Okay. So the thing that we advise you to remember for life-threatening condition, in any other kind of questions, yes, we go step by step as part of choosing option in the exam. We will always go next step like that. But in any kind of life-threatening condition where especially MI, pulmonary embolism, something which can kill the patient within seconds, that questions, we will always choose the most important option that's going to save the patient. Okay. Why not thrombolytics? It's easy because thrombolytics is not the first line management. If we have PCI, like a percutaneous coronary intervention, which is formerly known as angioplasty with a stent, PCI is the best option. Because what we do in PCI is that we insert a catheter into the arm or groin, and through that catheter, we take a stent and we put the stent into the blocked coronary artery. And it just opens up the coronary artery. It is really good. It has less side effect, less mortality rather than a thrombolytics. Thrombolytics has a lot of complications, possibility. Thrombolytics is the second line treatment. If we can't give angioplasty or PCI is not available, or the time is not permitting, we don't have much time to refer the patient from a rural to tertiary, that is the time our option would be thrombolytics. Okay, so if, yes, the idea is if PCI or angioplasty is in the option of a ST elevated MI, after aspirin, that is the choice of treatment. There is, please don't confuse that because I know it is confusing, but that is important to understand that it is a life-saving question. No, the question is always the same. If it is next step, next most appropriate, whatever it is after aspirin, it will be always angioplasty in ST elevated MI. So it is only aspirin. We don't add clopidogrel because you are taking the patient for an operation. If you give clopidogrel before that, patient will bleed a lot. No, we don't give thrombolytics before preparing for the catheter lab. That is completely wrong. It is either thrombolytics or PCI, any of them. And we'll discuss that, so don't worry. So because there is still a lot of things. We just started with the questions. Okay, move on. So I will come to this non-ST elevated thing later on. We'll discuss that. So, treatment. Treatment of a ST elevated MI patient. In a ST elevated MI patient, as soon as the patient goes into that room, our treatment will start with aspirin. Yes, we will go for morphine if patient has chest pain. We will give oxygen. We will give nitroglycerin if patient's blood pressure is not too low. So we will do all of them, but for the purpose of exam, it is a bit different. For ST elevated MI after aspirin, the choice of treatment, next best, everything is angioplasty or PCI. Same thing, okay? Now that we know that what will be the step-by-step management, what is the time period that we can actually go for this treatment? Not every patient who has an ST elevated MI can have PCI. So let's see. So initial non-specific management is what we discussed as a MONA treatment. Patients with ST elevated MI who presents within 12 hours of onset of the ischemic symptoms should have a reperfusion strategy implemented promptly. And the reperfusion can be obtained with a fibrinolytic therapy or a PCI, which is percutaneous coronary intervention. Patients presenting with a non-ST elevated MI will not benefit from thrombolytics. Okay, thrombolytics actually include a fibrinolytic and PCI both. So a non-ST elevated MI doesn't need a fibrinolytic therapy, doesn't need a immediate PCI. Later on, yes, we might need to put a stent in a non-ST elevated MI patient, but not as immediate like a ST elevated MI patient. Okay, so we discussed that ST elevated MI only will be benefited from thrombolytics. Non-ST elevated will not get any benefit. So we will not do that. Now, see these questions. That's the important thing. You can only go for, or you normally would go for immediate reperfusion if a patient comes to you within 12 hours of symptom onset. And within 12 hours, you can either do the PCI or you can do the fibrinolytic. So many of you have a wrong thinking about this, that before 12 hours, it is PCI, and after 12 hours, it is fibrinolytic therapy. It is wrong. So it's usually like within 12 hours, if a patient presents, we can do either of them. If PCI is available, that is the option always as the first. Sometimes they say it is a rural hospital and you don't have PCI available. And to transfer this patient to a tertiary hospital, you will need, let's say, 3-4 hours. So there is no point of wasting 3-4 hours to send the patient to the tertiary hospital. In that case, you would go for fibrinolytic therapy in the rural hospital. Okay? So that's when we choose this. So emergency reperfusion therapy, the choice is between PCI and thrombolysis. PCI is the best available treatment if provided promptly. It improves short-term, long-term outcome in patient who presents within 12 hours in comparison to thrombolytic. In general, a time delay of 90 minutes from the first medical encounter to the PCI is the maximum desirable. Now, please don't get confused with this line, because that's when you get confused. That you ask me always that it's written in JAM that it should be within 90 minutes, but patient came to me after 5 hours. So it is not the case. So this 90 minutes is the goal. It's the aim of us that as soon as a patient enter into our hospital door, within 90 minutes, if we can take this patient for a PCI, that is desirable, and that should be ideal. Okay, but it doesn't mean that if we can't do it within 90 minutes, we will not do anything about it. So as long as patient presents within 12 hours of symptoms, we can do the PCI. Okay. So 90 minutes is just like a delay of starting the treatment. Okay. For patients presenting with a ST elevated MI at a facility without PCI access, transfer to another facility capable of performing PCI usually takes too long. Where PCI is delayed or not available, reperfusion with a thrombolytic can be occurred. So are you understanding that this is what exactly I have told, right? Making sense now? So what if patient comes as delayed after 12 hours? If patient comes after 12 hours, then yes, this patient will need a angiogram. So you go for an angiogram. With the angiogram, you will be able to find out how much blockage is there. So what is angiogram? It's just like the same thing, like you put a catheter in and then the dye goes into the coronary artery and it can say that how much blockage is there in which artery. So if patient comes after 12 hours, you would send the patient for an angiogram, find out how much blockage is there, and you can do a like a elective stent put in or coronary bypass surgery depending on the level of blockage. So when patient comes within 12 hours, PCI is the goal because it's going to save the patient's life. But after 12 hours, you would not do as urgently as you would do if patient comes within 12 hours. Okay? But patient will get the same kind of treatment, but it will be just a little bit like a non-urgent basis. So let's say after 12 hours, if patient is not in a lot of chest pain, you would start the main treatment. If a patient is on any medication, you will do that, aspirin and everything. But then you would go for sending the patient for a coronary angiogram, find out where is the block, how much is the block, and then do the treatment, either stenting or bypass. Okay. So it is only the loading dose of aspirin. We don't give clopidogrel in a ST elevated MI patient before PCI, just aspirin 300. Clopidogrel is usually given in non-ST elevated MI where we would not take the patient into the theater straight away. Yes, so no thrombolytics are needed after 12 hours. That's a very important thing to remember. Yes, 300 milligram aspirin. Same. So within 12 hours of onset, you either do the PCI or you do the thrombolytic. After 12 hours, you don't do this. After 12 hours, you would just do a coronary angiogram and find out what will be the treatment for this patient based on the blockage. Very simple. Don't make it confusing. Okay. So that's what we have written in here. So the earlier the treatment is given, so that's the fibrinolytic or thrombolytic, and it has streptokinase, it has tissue type plasminogen activator, so all of the same thing. So the earlier the treatment is given, the greater the benefit. Greatest benefit is when a patient has ST elevation who had symptoms less than 12 hours. So within 12 hours, it is either PCI or thrombolytics. There are lots of contraindications for thrombolytics therapy. So before you proceed for that, you need to make sure they don't have any active bleeding disorder. They don't have any history of head injury. No, you don't suspect aortic dissection. No history of bleeding in the brain. No history of ischemic stroke within the last 3 months. So these are absolute contraindication. So late presentation. So if a patient presents after 12 hours, reperfusion therapy with either PCI or fibrinolysis is not routinely performed, especially if a patient is asymptomatic and hemodynamically stable. So asymptomatic, hemodynamically stable patient presenting after 12 hours, you don't need to do the reperfusion therapy. So the intervention at that time can be a coronary artery bypass grafting or a PCI. Okay, so it depends. We will come into that, like when to choose stent and when to choose the bypass grafting, depending on the coronary angiogram. So after 12 hours, if patient is stable, then you would not send the patient for a PCI or fibrinolytic. You would actually go for a coronary angiogram. This is one of the other thing in patients who you have selected for fibrinolytic therapy. So you're not going for PCI, which is basically a surgery. If you are choosing fibrinolytic therapy, clopidogrel should be given in addition to aspirin, unless contraindicated. Note, however, that if it is thought the patient is likely to require a bypass, clopidogrel should be withheld. That means if your patient is needing a surgery within few days also, normally you would not start the patient with clopidogrel. Just to start with aspirin. Clopidogrel usually will be added after the surgery. So that is the management for ST elevated MI. So what is the management for non-ST elevated MI? So let me have a look. So just 1 second. Okay, so it's not overtly written in John Murtagh anyway, but we can discuss. So for non-ST elevated MI, we know that they will not be benefited from thrombolytics. So for a non-ST elevated MI patient, the treatment is the initial treatment. So aspirin, clopidogrel. So that will be very important to start with. But one of the other important treatment for a non-ST elevated MI is heparin. So heparin is a lifesaver for this patient because it prevents further clotting. Okay, so aspirin, clopidogrel, heparin, this is really important. And then any other secondary treatment that can be added based on the patient's status. But that's usually the treatment of choice. And definitely morphine, oxygen. So monotherapy will be there, but only thing that we will add in a non-ST elevated MI is heparin. And also we would not go for any coronary intervention. That means no PCI and no need of any thrombolytics. So what will happen to their block? Because they have a block, right? So how we are going to treat a patient who has non-ST elevated MI? So the initial treatment is morphine, oxygen, all of the things. Aspirin is still important for non-ST elevated MI. Heparin is important. And after that, this patient would likely to go ahead with a coronary angiogram. Coronary angiogram will give us an idea that where is the block and how much is the block. So that's when it is important. So have a look. Okay. So when we do coronary angiogram in a patient, it can show which is really the worst artery or where exactly is the block. Is it the right coronary artery, left anterior descending, which one it is? And it can say that is it 30% block, 70% or 100% block. So any artery which has more than 70% stenosis, that is significant block. Okay, so if it is only one or two vessel having 70% block, then we go for stent. If it is three vessel, so all the three main vessel has got more than 70% blocked, we go for CABG or the bypass surgery. Or in case of diabetic patient, even two vessel, they will go for bypass surgery. All right. So this is how we can actually think that with the non-ST elevated MI, patient has MI, patient has a block. Although we are not going for thrombolytics, patient will need something. So that patient goes for an angiogram and we find out whether we are going to go for a stent or a bypass grafting in that patient. Okay. Clear everyone that how the non-ST elevated MI treatment will happen? Now let's have a look to a question. So we have a questions for non-ST elevated MI. This one. So a man, so let's say 50-year-old man comes to the ED with a chest pain lasting for an hour that is crushing in quality, does not change with respiration or position. ECG shows ST segment depression in V2 to V4. You have given aspirin. Now, although in this case, they haven't mentioned about any kind of like cardiac enzyme, doing a cardiac enzyme will be important. But let's say it is just happening for the last 1 hour. Even if you do cardiac enzyme, you will not be able to actually get anything because it can take 4 hours to get increased in the blood, right? So doing a cardiac enzyme in this patient not going to help us. But yes, we can do it. But in this case, when a patient has got significant history for 1 hour crushing chest pain and has got a ST depression, it doesn't matter that if it is ST depression or normal ECG in this patient, but the symptoms, crushing chest pain for an hour, it has a high risk that it could be a MI. So in this patient, we know that it is not ST elevated MI. That's why we don't need to take this patient for a angioplasty, right? But what will be the next treatment? Next treatment is aspirin, which we have given already. What else we can give? So next step after aspirin. So if we look over here, heparin is the option because this is again, it is life-saving because if you give heparin, it will not become a full-blown ST elevated MI because left untreated, more and more clot will happen and it will become a full blockage and becomes ST elevated MI. So there are a lot of incidents where patient initially came with non-ST elevated, ended up having a ST elevated MI because the treatment was not given. So heparin will prevent further clot formation. It does not dissolve the clot that has been already formed, but it is important. When the patient has ACS, there is no ST segment elevation, there is no benefit of thrombolytics. Nitroglycerin, morphine, oxygen are not associated with a clear reduction of mortality. So again, in MI case, mortality comes first than anything else. In a lot of other questions, as I say, that you would choose a step-by-step management, like aspirin, morphine in that way. But in MI case, this is a bit different. We look into what's going to save the patient, what's the most or what is the best option that we have got for this patient to give now. So after aspirin, the best option for that patient will be heparin. Okay, not thrombolytics. We don't need to give abcimab because that's usually third line. Yes, morphine, nitroglycerin, beta blocker, all are okay, but they are not the lifesavers. Okay. Between clopidogrel and heparin, heparin will come first. Yes, so that's for non-ST elevated MI. Aspirin is the first choice, and then heparin. It is right that if in the options there was an option of doing a troponin, we would do that. Even though the likely chance that it would not be elevated, still we would do that after like by seeing this patient. But that is not in the option. Okay. So if there was an option of troponin, yes, I would do that just to get the baseline at least. Sometimes patient even within an hour it gets elevated. So yes, we would do that, but that's not in the option. Okay. No, it's not, it can't be a GERD, right? So reflux will not be a crushing chest pain. And you would not get ST depression also. So crushing chest pain, it's not a GERD. Yes, if it is ST elevation, angioplasty. Yes, so if we have troponin and heparin both in the option, we can go for troponin because it is very common that we would check the troponin in these patients before we treat the patient. Okay, it's unusual in a real life scenario that we would start a patient with heparin before knowing the troponin. Okay, so exam scenario sometimes might not fulfill what we see in a real life, but yes, in a real life, I would definitely do a troponin first in this patient. Ticagrelor is not a treatment of ST elevated MI, Dr. Shabir. There will be some better option than ticagrelor. Okay, so right now we know the treatment of ST elevated MI, we know the treatment of non-ST elevated MI. What about treatment of stable angina? So that's when we will discuss about some of the tests that we do. So we have got a patient who comes to us with a stable angina. Time to time, patient come. So heparin is, so how about LMA? So that is low molecular weight heparin, right? So we just discussed about heparin, which is we give in non-ST elevated MI. So let's talk about the stable angina. A lot of time, patient will give you the investigations for a stable angina patient. So we have got a patient who comes to us with a kind of a chest pain, which comes with exertion, gets better with rest. And we know that it is a possibility of a stable angina. But we want to know whether it is really bad enough that this patient needs some treatment, or whether we can prevent a myocardial infarction in this patient. That is the time we do some stress test. So you have heard about doing a stress test. So a stress test is mainly for angina patient, right? So the most common stress test is exercise tolerance test, ETT. So it is usually done when we are not completely sure whether it is an angina or something else, or we have done the ECG, ECG is not showing anything. So a stress test is done in a patient who has a chest pain and there is no baseline ECG abnormality. So ECG is normal and your patient is able to do exercise. So because this patient needs to run on a treadmill, if they have a very bad osteoarthritis of the knee joint and you are sending them for a treadmill running, they will curse you. So it's important that there is no baseline ECG problem and they can exercise. Okay. So once this is fulfilled, you will send the patient for a stress test. What will you look for in the stress test? In the stress test, when you put the heart under exertion, sometimes either patient says that I'm getting a chest pain, or you might be able to see some ST depression in that patient during the treadmill running. So this is what you would look for in a stress test. So either patient complaining chest pain, or there is ECG showing that there is a ST depression. What if you cannot read the ECG because there is an abnormality? So sometimes, let's say that there is an abnormality in the ECG, like there is a left bundle branch block, left ventricular hypertrophy, patient is on digoxin, or patient have pacemaker. So when there is an abnormal ECG, we can't rely on a exercise tolerance test or stress test. So ETT is not done in a patient who has a abnormal ECG already. What we would do in that patient, for that patient, we do the nuclear isotope scan, or we have got a resting ECG, or like you can say echocardiogram. So what is this nuclear scan? Commonly known as thallium scan also. So what you do in this patient, that you give a dye, and the dye have this nuclear isotope, which is thallium, and the dye will, so the live and perfused myocardium, which means the heart muscle, will take the thallium. But let's say all the part of the heart has taken thallium equally, except this part. That means that most likely that the artery that supplies this part might be blocked a little bit. And that's why this part is not getting enough dye. So that's what we look for in the thallium scan. So it's a kind of a dye test where dye goes into different part of the muscle of the heart, and it gives us an idea whether any part of the heart is not getting any blood supply. So that's one option. And the another option would be to do the echocardiogram. A normal myocardium will move equally. So myocardium or the heart muscle need to pump, need to contract to pump the blood to the body. So that contraction is a movement, right? And all the myocardium should move equally. If some part is not moving as it should be, which is known as akinesia, hypokinesia, or dyskinesia, that can be also a finding. We call it regional wall motion abnormality. So if a part of the heart is not moving as it should be in an echocardiogram, that can also suggest that maybe that part of the heart has some blockage. Okay? So this just gives you an idea. It doesn't confirm a lot of things, but it can say that, well, there is an abnormal heart or something is going on in the heart. Clear? So if a patient baseline ECG is abnormal, then your next choice is either doing a thallium dye test or a isotope test or a echocardiogram. Does it make sense? So abnormal ECG means they have some kind of abnormal finding, like left ventricular hypertrophy, bundle branch block. So it is not normal. Okay. So it is not like that abnormal. So doing a stress test or doing this test means if a patient has got left ventricular hypertrophy, doesn't mean that they have got a blockage. Okay. So we are trying to find out whether there is a blockage. That's why we are doing this test. But when they have an abnormal ECG, it's not actually ideal to do the stress test. So thallium scan is much better than an echocardiogram because it's a dye test and it can give us better information. So the next thing is, what if your patient cannot exercise? So this patient can exercise. So this patient is able to exercise, but the problem is ECG abnormality. What if your patient cannot exercise? Then you have to give something to the patient which will make the heart as if it is working. So you do a chemical induction. So we have got few chemical which can be given, and it can actually make the heart work, or it can actually make the heart as if you are running. So it is called dipyridamole or adenosine. So what we do is that we do the dye test like thallium scan, but this patient cannot run on a treadmill. So we are going to give this chemical to make sure the heart is running, or as if heart is running. Patient is not running, but it will make the heart work, okay? Or it will make the heart as if it is doing some exertional activities. So if a patient cannot do exercise, you do a chemical-induced scan. So chemical-induced thallium scan or a chemical-induced echocardiogram. Okay. So the same test, but in here you're giving the chemicals. So this will give you a bit of an idea that when to do what. First of all, if I give you a good summary is that, let's say you have got an angina patient. First thing you would ask that, is there any ECG abnormality? Is the patient able to exercise? If yes to both, so no ECG abnormality, and exercise is fine, you send the patient for exercise tolerance test. Your patient has a baseline ECG abnormality. So ECG is abnormal. Then you have to do a thallium scan. So it is also an exercise thallium scan. And this is an echocardiogram, which is also exercise or a stress echocardiogram. Your patient is not able to exercise. Then you do a chemical, which means you can do a dobutamine, which is a chemical dobutamine thallium scan, or a dobutamine echocardiogram. Very straightforward if you actually understand what I'm talking about. Okay. So that's actually how it should happen in your mind that, well, this. It's not about cannot read ECG. It's mainly about ECG abnormality. Yeah, so treadmill and exercise test is same. So if ECG is abnormal, so we have got abnormal ECG, which means that maybe patient has a LVH, patient is asymptomatic and is an incidental finding. Still we perform no. It is only for symptomatic patient. If a patient comes to you with a symptoms of ischemic heart disease, chest pain, then only you would do this test. It is not a screening test. How we do exercise thallium scan, it's not a question for the exam. So a lot of things we still have to discuss. Let's not go into things that is not needed. Okay. So yes, so it is for ischemic heart disease. So if a patient has got angina, chest pain with exertion, then you would do a ECG. Okay. So let's say the baseline ECG is normal. Patient is able to exercise. Then you send the patient for a exercise stress test, which is the running on a treadmill. Let's say ECG is abnormal, like not abnormal like ST depression, but some other abnormality. In that case, you can't do a stress test. You have to do either a thallium scan or a echocardiogram. What if patient can't exercise? In that case, you have to do the chemical ones. Okay. Yes, so that is the reason, because your patient having a chest pain, but baseline ECG showing normal. So you need to actually let the patient exercise or put the patient heart in a strain and see if there is any ECG finding. That's the deal with the exercise tolerance test, right? Because you want to see what happens when the patient exercise. Okay, so this is when it comes. So let's say that we have got finding positive. So a stress test came back positive. So either it's a ETT, chemical stress test, or like exercise test. So any of the test comes back positive, that patient has a ischemic heart disease. or coronary artery disease. For that patient, we do a prophylactic angiogram. And in the angiogram, as we discussed, if it is 1 or 2 vessel block, we put a stent. If it is 3 vessel, more than 70% block, bypass. So that is a prophylactic treatment to prevent a heart attack in a patient who has stable angina. So that's mainly all about actually the heart conditions. There's a little bit about Prince-Metal angina. We discussed that it is a coronary spasm. There will be ST segment elevation. When you get a ST segment elevation, you would think that it is ST elevated MI. And you will treat the patient as if it is ST elevated MI. But when you take the patient for angiogram, there will be nothing wrong. So when you see angiogram is normal in a patient who has ST elevation in their ECG, that is this variant or Prince-Metal angina. Prince-Metal usually occurs during rest, sometimes even at night. So the treatment for this patient, so you can see exercise test, coronary angiogram, all are normal. So you have to give something which can dilate the coronary artery, which is our calcium channel blocker or nitrate. So any of this, you can give any calcium channel blocker, nifedipine or anything, or nitrate. So that is the treatment. Once you treat them, the prognosis is very good. Okay. Moving on to another cause of chest pain, which is aortic dissection. So you guys are clear about stable angina, unstable angina, myocardial infarction, all the treatment. Aspirin is fine. You can give aspirin unless a patient has any kind of like, if it is a aortic dissection, in that patient, we might not give aspirin. But like in a suspected MI patient, giving aspirin is fine. It's not going to harm the patient. No, if any of them, so if exercise tolerance test is positive, your task is to go to this. So see this one. I know it is a bit confusing, but you can listen to the videos again. So see this is exercise stress test. If ETT is abnormal, you will go for angiogram. Okay, aortic dissection. So aortic dissection is a condition where there is a tear in the aorta. And the patient will come to you with a sudden severe ripping, tearing sensation in their chest, usually retroesternal, and it radiates to the back, or sometimes it can even radiate to the abdomen, flank, or anywhere. So aortic dissection, the type of the pain will give you the diagnosis. So sudden severe retroesternal chest pain, tearing, ripping sensation radiating to the back. If you check the blood pressure or pulse, you will see that there is a bit of difference between the two extremities. So right arm or left arm, blood pressure, pulse will have some difference. So when we think that a patient might have aortic dissection, what we will do next? Next thing is first confirm the diagnosis. The definitive diagnosis comes from transesophageal echocardiogram. If that is not possible, we do a CT angiogram. Now, very important to know that the treatment. So if this is your heart, and that's the aorta, and we know that aorta has got 3 main vessels. So we have brachiocephalic, left carotid, and left subclavian, right? If dissection happens proximal to the left subclavian artery, That's called type A aortic dissection. Type A aortic dissection is very close to the heart and it has high mortality. And emergency surgery is needed for this patient. And if there is a dissection distal to the left subclavian artery, that is known as type B dissection. Type B is not that severe like type A. And for this group of patients, the first treatment is to reduce their blood pressure because almost half of them will have very high blood pressure. How to do the blood pressure control in this patient? Your first line is beta blocker. So ideally, IV labetalol is the treatment of choice. If IV labetalol is not working, then we can go for IV nitroprusside. If we give nitroprusside first, blood pressure can suddenly drop significantly, and it's not good. And if needed, then we can go for surgery in type B as well. But type B, the treatment first is controlling the blood pressure, and type A, the treatment is mainly surgery. Okay? Yes, so CT angiogram or transesophageal echocardiogram, both of them, like in an unstable patient, we actually can't do much. But these patients are unstable. So it doesn't depend on stability. But if a patient is like, has a lot of comorbidities, then yes, CT angiogram will be handled easily than a TOE. TOE is much more invasive. Okay. But if question asks what is the most appropriate or definitive investigation, that is usually TOE. So type A is when the dissection is proximal to this left subclavian artery. So any dissection in this area will be type A. Type A will require surgery, and type B, which is any dissection after this subclavian artery, that will be initially treatment is pharmacological control of blood pressure. Okay, so that's all about tonight's session, guys. A lot of things to discuss, and there is one thing you can also do is there is chapter 30 in John Murtagh about chest pain. Everything that we discussed is a combination of John Murtagh and Kaplan step 2 anyway, but you can give it a read in your own time because this is an important topic. So you can go into chapter 30, give it a read, and you'll find out everything we discussed is there. So just give it a read in your own time only once, that will be okay. All right. Any questions from tonight's session, guys? Yes, we have Kaplan in the Google Drive. Yes, so all these classes are recorded, and this is definitely a class which you need to listen again. Okay, so definitely give it a read again. So we'll provide the recordings. No, chapter 30 is for chest pain, and that is what we have discussed today. And other chapters we will discuss in our next class. We will always go for the John Murtagh 8th edition at the moment. No one need to wait for until the trial class ends. So if you are going to join the sessions, I would definitely advise that start the process, because even the process can take a week, because we can't give you access to all the portals and everything within a week time. There's a huge amount of candidates who join us. So we try our best to answer their queries. So a lot of questions, a lot of things. So it's not easy to answer a lot of questions which is already given also. but sometimes we do that. So what happens that, like, even you can see that if you send an email today, we might not be able to reply immediately. It takes even nowadays a day to reply you back. So please keep your patience. And if you want to join, then then definitely send us a message or send an email so that we can at least send you an invoice, start the process. So you don't need to wait until the trial class. No, I would not recommend to use John Murtagh 7th anymore. It's outdated now. Recording of this class will be provided tomorrow. That's wrong. So we will be able to do a ECG. So we do a baseline ECG, and baseline ECG is normal. Patient has chest pain. Then we do the exercise tolerance test. It is better not to go into that, Dr. Arogya, that out of morphine, oxygen, nitrate, which one is best, because it is just going to confuse you in the exam. Think that after aspirin, you are going to choose the angioplasty in the exam. But if you really need to choose, then morphine will come first. Let's say there is no angioplasty in the option. So after the free trial class is over, the schedule of the course class will be given in a separate Facebook group for the course student. We don't use infarction like that. There is either, so even non-ST elevated MI is an infarction, right? So it is either non-ST elevated MI or is it ST elevated MI. So they will not have same ECG. Dr. Anuja, please make sure to contact us as soon as possible if you have waited that long. So make sure to send me a message or you send a message to our email and just inform that you have been waiting. Yes, this is all provided in the lectures. You don't need to make a WhatsApp group because we will include you in a Telegram group where we have all the students from the past batch as well. So yes, you can do that. So that becomes easier for us rather than sending you the invoice. So you can actually make the payment from the website. And if you make the payment from the website, then you can send us an email that you have made the payment and include the receipt that you get after the payment. And in that way, your one step is done. So you will get some other information that how to make an account in the portal, and you can start getting the access. So definitely worth doing that if you are waiting for our reply for an invoice. Okay. So I've shown you that if you go to our website and choose the 5 months MCQ course, you can see a subscription option. So just create an account and they will take you to the payment page, and then you can just send us a message. Good question. So if a ST elevated patient has a thrombolytic already, they would not proceed for PCI anymore when they go to the tertiary hospital. What will happen that when they go to tertiary hospital, they can organize a coronary angiogram, and that can give us an idea that if there is any block left or how much block is there. Yes, John Murtagh is not available in portal, but we will provide a soft copy. There is a Telegram group. So after these free sessions are over, we will add all of these things in your Facebook group. So if it's in Pakistan, there is no Telegram, then we might just, so there will be a messenger group as well. So that's also another thing we would add you. So you can always come into that messenger group. Yes, so once you make the payment, we will add you to our first aid Facebook group for the course student. Yes, so platelet low, we can give aspirin, but not definitely not clopidogrel. And Dr. RH, for old batch student, where we can find the file for random question solving of these pre-sessions. So we add all the random questions solved into the sample question file. So there will be a sample question in your portal. That's where we add all the random questions. Yes, you have to pay for creating AMC portfolio. So when you create the AMC portfolio, I think there is a small payment when you do the Epic account and all. Okay, so let me show you that where to do the subscription so that it's a bit easier for you. So if you just write firstaidamc.com in Google, this page will come up. So write firstaidamc.com, and then you can go to this subscribe option. So there is a subscribe option in here, or you can also go to this one. So that's the MCQ course you are joining now. So if you go to the subscribe button, in here you will need to fill everything. Then they will take you to the next button. In the next button, they will ask you to upload some photos and all. And then at the end, you will see that there is an option of payment. Okay. So they will say that, have you already paid? Then click yes. If you haven't paid, then subscribe. So if you click on that subscribe button, they will take you to the payment page. You can make the payment there and then contact us. Okay. And the email address that you will be sending email to us is, I'll just show you. So if you go to the website, you will be also able to find out our email. So let's say you have clicked on that 5 months course. So let's say you came in here. So you go down. So if you go down, you have this email address there. So you can just send an email in here as well. Okay. So to get the AMC number, you will need to have an Epic account. We will discuss about Epic account and everything in our orientation class. UWorld Psychiatric will be added in the drive. Yeah, so if you have any doubt, anything that you didn't understand in any questions, you can always ask in the next class. Okay. Brilliant. Let's finish it here tonight. Thank you all for your active participation. We'll see you in the next class. Take care. Bye.